classification and adult spinal deformity. Kind of topics we're going to hit on is first just what makes a good classification, then important measurements that we look at, which we've hit on before. We won't spend too much time on that. Then we'll go through historical classifications and come to the more current classifications and things we use. Just trying to determine what exactly is a good classification system. It must have characterize the nature of the problem and then guide treatment and decision making. And ultimately, in orthopedics or any other specialty, you want to improve the outcomes based on this. And it should also establish expected outcomes for the natural history of a condition or an injury. And so you can then have a uniform kind of reporting and results for this, whatever you're looking at, so that surgical versus non-surgical treatments can be looked at, compared, and the results from different centers can be compared at the same time. And then it has to be both reliable and valid. Reliability is the precision systems, so should have both of these within it. And then we start talking about kappa values, which was introduced, I think, in the 1960s from this paper, and then going forward. So that's just the basis of the cap value agreement above and beyond that related to the chance alone. And then those are the kind of what you need to have a good classification system. And then when you're looking at these in terms of adult spinal deformity, our measurements drive a lot of these and help us go along with these. I know we've had multiple talks on these before, so we won't spend too much time on them, but things like cov angle, lordosis, sacral PI, PT, sagittal balance, those are all going to come into play as we move forward, looking at the different classification systems and how they're used and how to make them good classification systems. So they're very lumbar and combined double primary, and that remained until the 1950s when Ponseti retrospectively looked at close to 400-ish cases of idiopathic scoliosis, and then trying to change that. Ponseti looked at 5 curve patterns, which corresponded closely with what Schultes had previously described, and then he described which were most likely to progress, the most common age, onset, and descriptive characteristics. So that's kind of the first crack at it. And then 1973, Godstein et al. Looked at etiology classifications once again, where they expanded on the curve patterns. Idiopathic would be something that didn't have an identifiable underlying cause and was further divided by age, kind of as we look at so infantile under 4 years old, juvenile 4 through 9, and adolescent between 10 years and scheduled maturity, and those have changed over time as well. And then congenital was broken down into abnormal bone development, failure segmentation versus formation, resulting in various deformities. And then you get down into neuromuscular, which is neuropathic or myopathic scoliosis. And then you get down into neurofibromatosis, which has its own category. And then mesenchymal disorders as well, both congenital, such as Marfan's, or acquired, such as rheumatoid. And the final was due to trauma, which included fracture. But this included scoliosis due to surgery. And so this was descriptive and good with the natural history. It still did not necessarily allow for deformity in an adult setting to look at ways to describe it or compare treatments or moving forward. And so then King in 1983 had ways to describe a method for selective fusion, and how they determined which levels to fuse was kind of the basis of the study. And so it's retrospective review of patients under surgical treatment for idiopathic thoracic or combined thoracolumbar scoliosis. And they defined scoliosis as curves here, which they showed here, type 1, 2, 3, 4, 5 is listed there. And then, which we won't spend too much time going into just because we'll kind of move on from that. But note that type 2 curves or things that they looked at that come into play later on. Stable vertebrae, which is the vertebrae which is most closely bisected by the line defined as perpendicular to the iliac crest, centered on the sacrum, and they also noted type 2 curves, or could be selectively fused down to the stable vertebrae and appear to have spontaneous correction of lumbar curve. But once again, this is mainly for AIS, not adult deformity. It didn't account for degenerative conditions. The main reason why there wasn't as much of this looking into it at this time was that adult kind of deformity and treatment of this was less common at that time than adolescent idiopathic scoliosis. So there wasn't as much of a drive at that point to come up with different classifications. So now coming to 2020 or 2001 with lengthy classification, something that we are more familiar with from as residents and fellows and things like that. And so we've been through this with the previous presentations here, so we won't spend too much time beating this one down. And so, once again, mainly for adolescents, failed to identify important parameters that have been found to correlate with pain and function in adults. But overall, as a classification system, very good. Had a kappa value of 0.92 among researchers and 0.893 to 0.970 with the 7 reviewers who were selected randomly from within SRS, and also has some criticisms that there were 42 different curve patterns once all the modifiers were applied. So, debates there. So now moving more towards adult scoliosis. So this study from Schwab et al. Prospective self-analysis and evaluation of nutritional and radiographic parameters in a series of healthy adult volunteers older than 60 years old. They had 75 patients total with no prior history of spine surgery and no history of scoliosis. And so their main goal was to look at, assess the prevalence of scoliosis and assess for any correlation with SF36 scores and nutritional status. No significant correlations were found. However, the prevalence of scoliosis at that time they found was 68%, which was much higher than 1.4 to 32%, which was previously reported in the literature. This was with definition of Cobb angle greater than 10 degrees. And that was shown in groups 2 and 3 in this pie chart. Is kind of what is that subset of patients. So this showed the importance that there needs to be a need to define and classify adult deformity that meets those kind of criteria we talked about earlier, especially in the setting of more and more older patients coming in with this problem and needing ways to look at this. So 2005, IABI proposed an etiologic classification for adult deformity. Sorry if I butchered his last name. But within this classification system, you look at which type of curve would progress and then what treatment, if any, was appropriate. So it was split up into 3 primary types. And then the third type is divided into A and B. Type 1 is a primary degenerative scoliosis or de novo form. So this is mainly located thoracolumbar or lumbar spine and develops within the confines of like limited disc degeneration in one or more segments. It could also, another term used to describe it when you're looking into this is a discogenic curve. Apex on these is usually seen L3, 4, L2, 3. And they typically only develop in adults and result in some form of flat back or lumbar kyphosis. The sagittal malalignment is what they kind of attributed the pain in these patients to. Type 2 curves are more progressive idiopathic scoliosis that has been present since adolescence or childhood. And this was sagittal deformity was almost always present, and then a flat back syndrome with loss of physiological lordosis resulted in kyphosis as well in some of these subset of patients. And then type 3 is secondary degenerative scoliosis, which is usually thoracolumbar lumbar segments, either within the spine or it can occur from either within the spine or outside the spine. It's a result of idiopathic congenital or neuromuscular conditions that result in a lumbosacral anomaly in this subset of patients. And then 3B is due to bone weakness, such as metabolic bone diseases, osteoporosis, kind of what we look at. Now, this did not, although, this is etiologic classification, it doesn't do anything about the severity of these, and it did not, necessarily change the way these were treated, but it does kind of provide the groundwork for things moving forward. And so here we can put the SRS classification for adult spinal deformity, low at all within SRS proposed this classification in 2006. 2006. And there were, prior to this, pediatric scoliosis, like we've kind of talked about before, was what was looked at more closely. And so this is looking at more important considerations within the adult spinal deformity world, looking at degenerative changes, including stenosis, spondylolisthesis, rotational subluxation, which were considered, critical in any type of adult spinal deformity classification system. And then also looking at global imbalance of the spine and the sagittal and coronal planes, because that's a little more rare in adolescent idiopathic scoliosis, but more impact on health status and treatment options in the adult setting. The role of non-operative care, decompression alone, limited stabilization, or long fusion had not been well defined and still remains poorly defined due to this. There was no valid classification system at that time that specifically was looking at this. And so in this system, they defined 6 major coronal curve types: single thoracic, double thoracic, double major, triple major, thoracolumbar, and lumbar. And then the kind of stratifying these was the thoracic curves, so the apex between T2 and T11, 12 disc, thoracolumbar between T12 and L1, lumbar between L1, 2 disc, and L4. And then when looking at treatment for this, or for the classification, primary thoracic required a curve of 40 degrees and a C7 plumb line that's lateral to the apical vertebrae. And that 40 degrees was chosen as the basis for this to identify curves of significant magnitude to warrant consideration of extension of instrumentation and fusion higher up. And then upper thoracic curves are structural. If the first thoracic rib or clavicular tilt is greater than or equal to 5 degrees, with the leveled side ipsilateral to the apex of deformity. And then thoracolumbar lumbar curves include a curve magnitude of 30 degrees and a central sacral vertical line that passes lateral to the apical vertical body, vertebral body of the curve. Sagittal, a sagittal only deformity consists of no major coronal curve and a sagittal modifier that is out of normal range, which is listed there. And then the lumbar degenerative modifier was added to quantify the lumbar degeneration that's often there coming along with any type of adult deformity, but not typically present with any juvenile or adolescent deformity. And then global balance is used to identify coronal or sagittal imbalance. So when kind of going back to my original slide and how you assess whether it's a good system, this had 14 surgeons in regards to reliability. 14 surgeons completed evaluation for 25 cases. Their kappa was 0.64 for a curve. The regional sagittal modifier was 0.73, lumbar degeneration 0.65, and global balance 0.92, which all fall within that substantial to excellent range. And so this now provided the groundwork for comparison of like cases between study centers, and what's finally important to classify these and move forward with treatment options. And so that was the goal of this. And then within the recommendations that they had based on this subset of patients that they looked at, the intra-observer recommendations for a caudal fusion level was 0.77, and within 1 for the cephalad level with a kappa of 0.56. But this system, or this classification system, did not include things such as presenting symptoms, comorbid conditions, age, and other epidemiological factors that can affect treatment and outcomes. So around that same time, Rusoli was publishing his classification, adult sagittal alignment. In his words, normal coronal alignment is well defined because that should be straight, but the natural curve of the spine and the sagittal plane makes it hard to define what is normal. And so there's significant variance within this. So an asymptomatic population is used to help define this normal, or there's significant variance even within the asymptomatic population. So you have to, it's very difficult to find this normal value, but he had 160 volunteers, no history of scoliosis or chronic back pain, and had full-length AP and lateral views. Then looked at the sagittal curve into 4 types. Tried to break down into 4 types, and so he used different radiologic parameters to help delineate these curves. So sacral slope, and based this on for types for the type, he used this to classify them originally, so less than 35 degrees for 1 and 2, 35 to 45 for type 3, and greater than 45 for type 4. And then before 1 and 2, to differentiate between 1 and 2, he looked at lordosis, tilt, angle, apex. If it fell within L5, it was a type 1. Within L4, it was a type 2. And then, so this was essentially a cross-sectional study used to identify normal anatomy. However, they did note that asymptomatic patients usually were type 3, while patients with symptomatic disc herniations were often type 1 and 2, and those with claudication were typically type 4, were kind of some of the things they gained out of that study. So at that point, parameters such as sagittal alignment begin to look at more closely. Lafarge et al. Looked at this and published this study in 2009. So they had 125 adults with spinal deformity. They had full-length freestanding radiographs of the spine and the pelvis, and patients filled out health questionnaires as well at the same time, HRQs, and at that time, they trying to identify different factors that were playing a role in adult deformity. There was no correlation identified pertaining to coronal plane parameters. However, when you looked at the sagittal vertical axis and truncal inclination, they correlated with ODI, SF12, and SRS measures. Pelvic tilt also showed a correlation with both quality of life measures as well as sagittal vertical axis, and they determined that high values of pelvic tilt with compensatory pelvic retroversion for sagittal alignment was also something they gleaned from this study, which comes into play later. And then as the pelvic tilt increased, you can look at these charts, the ODI increased, and SF12 scored, and physical components decreased. And so now the authors looked at combining pelvic tilt with sagittal vertical axis, and they created 4 categories in which they performed an ANOVA analysis, and that's how they came up with the categories 1 through 4. And this is important because it further showed important radiographic parameters that will help with disability and quality of life. Looking at those measures and putting those into play altogether, and that those are important in a good classification, and something that some of the other ones we talked about before were lacking. So if you can restore these theoretically, it might help guide, or that should be the goal of treatment, potentially help solve some of the patient's issues. 2012, this is the validation study of the updated classification system. It was, once again, SRS, Adult Deformity Committee. They had 9 readers that graded 21 marked cases, and then kappa values were calculated within the subset that intro observer values of 0.8 and 0.87 for the 2 readings, and then when they modified it, 0.75, 0.86, I think, or 0.9 for pelvic incidence minus lumbar lordosis, pelvic tilt, and sagittal vertical axis. So good reliability and accuracy here. And then when you're looking at this specifically, the coronal curves are simplified now to thoracic, thoracolumbar, or lumbar only, and double with 30 degrees used as the cutoff. Thoracic curves greater than 30 with lumbar curves less than 30 were defined as thoracic only. And similarly, thoracolumbar or lumbar only had a curve greater than 30 degrees with a thoracic curve less than 30. That's how they kind of changed that. And then a double curve had both thoracic and thoracolumbar curves greater than 30. And then 3 sagittal modifiers were also added in within this study. Pelvic incidence minus lumbar lordosis with the parameters noted there within the sagittal modifiers column. Pelvic incidence minus lumbar load. And then we talk about global alignment, which is the SVA, which is noted there, and then the pelvic tilt as well. So this gave more numbers there. And so there's an example of breaking down this curve on the right and how it would be classified just there. And so they found good reliability for the curve type and modifiers within the entire classification system. And then they also, now that you incorporate sagittal alignment and pelvic alignment, it underlines the importance of the spinal pelvic alignment, like we talk about all the time, especially in the setting of pain and disability. And so as this becomes more and more prevalent and you're treating adult spinal deformity, you have an evidence-based way of treating it. And so this is one way that you can apply this classification system, and it helps you better understand these curves moving forward. And then Bruce Lee also continued to publish at the same time in regards to this agile plane alignment. And so this was a 2018 study, and they kind of readdressed the classification system, and basically they wanted to look at adding some kind of modifiers within there. And so you get the anterotated pelvis is included in this study. They once again assessed a lot of the same things that did before: pelvic incidence, sacral slope, pelvic tilt, lumbar lordosis, lordosis tilt angle, total number of lordotic vertebrae, C7 plumb line. And so then this is when they kind of came up with kind of the modifications. And so the sacral slope is less than 35. The curve is either type 1 with, and if you have less than 3 lordotic vertebrae, in that setting, it's type 1. If type 2, if more than 3 lordotic vertebrae, and then it's a type 3 if the sacral slope is between 35 and 44, and if the pelvic incidence is less than 50 and pelvic tilt is less than 5, then it's a type 3 anteverted pelvis AP. And then finally, if the sacral slope is greater than or equal to 45, it's a type 4. And so that's further breaking it down. And once again, they through this study, some of the things they take out from it is that there's a high correlation between global lumbar lordosis and sacral slope. And they also noted that females in general had a lower pelvic tilt, which they thought represented an important characteristic in female adult deformity correction that should be kind of kept in mind, and that potentially restoration of lumbar lordosis may be more necessary in women. And then they also did note that their population was fairly small and composed mainly of young adults and Caucasian subjects, so that's something to be taken into account when you're looking at it as a whole. And so we've talked about sagittal balance this whole time, so now a little bit about coronal imbalance. These are articles that Dr. Mundis had sent us previously when myself, Jay, and Amber were this is the less talked about subject and something I felt, I didn't really know much about coming to this. And so in 2016, Bao et al. Attempted to address coronal deformity through this study. So he defined 3 types. Type A is considered balanced when the coronal balance distance, or the horizontal distance between C7 plumb line and the central vertical sacral line, is less than 3 centimeters. Type B is when this line is greater than 3 centimeters and the line is displaced to the concavity of the lumbar deformity. And type C is when this is that measurement is greater than 3 centimeters and displaced to the convexity of the deformity. And so this was a kind of 2-stage prospective retrospective study. And so the first one was the prospective part, looking at the coronal balance. Stage 2, they had 99 patients who underwent posterior only correction for the degenerative lumbar scoli, and they looked at SF36, ODI, VAS scores that were attained, and from that they were able to find that type C were more likely to have continued coronal imbalance post-correction. That's kind of what they gained, and they also found that patients post-operative that had postoperative balance were more likely to have higher VAS and SF36 scores, underlying the importance of correcting the coronal balance as well. And another kind of note from that is that when correcting type C imbalance and asymmetric osteotomy to correct that deformity at the apex may actually worsen the coronal imbalance. So they recommend a leveling procedure below L4, restoring the horizontal level of L4-5 prior to correcting the concave side of the main curve. And one more. Yep. So this is the when that study. So one more kind of looking at coronal imbalance is Obeid. So Bao only looked at degenerative lumbar scoliosis, but Obeid looks at trying to include this deformity going up into the thoracic spine as well from a coronal alignment standpoint. Here he has 2 main curves similar to Bao, and in this it was either you were convex or concave side of the deformity was the first part looking at. Then type 0 is no alignment, type 1 is concave, and type 2 is convex. And then after you decide to which side it falls on, you then assess the flexibility of the curve with side bending radiographs. And at times these were done with either over a bolster or a post, as well as and then you look at the location of the curve. So from this, which the table kind of breaks it down a little bit more, they were able to identify that the curve was identified, or that the Convex malalignment, once again, requires special attention. Correction of the main curve in isolation could worsen the malalignment. And so overall, they kind of took away from this. Coronal malalignment is fairly common in this adult spinal deformity, whether it's patients that have surgery or not, and it's something that's not as commonly talked about. And so you have to talk about the direction of that coronal malalignment in relation to the main curve of the deformity. So in concave coronal malalignment, which is the type of ones in this setting, the correction should be obtained at the apex of the main curve is one of the recommendations, and you might need a 3-column osteotomy depending on the flexibility. In a convex curve, which is the kind of type 2 subset here, the correction should be obtained at the lumbosacral junction. And then in the coronally aligned, or the type 0, to avoid any new changes, you should avoid hypercorrection of the main lumbar curve, as that can set you off in a bad path. I think that's it. Yeah, that's a lot, and try to just put the tables here so when someone wants to go back and look at these, it makes it easy to find all the classifications. And there's more floating around out there, but I thought these were the relevant ones.
Awesome. Thanks, Cam. That was a really good comprehensive overview. Did you happen to run into Larry's adult idiopathic classification?
I think I did. No, I should have. I don't know why I didn't include that.
Okay. That'd be the other one that's reasonable to look at, because it's a little bit more recent than the Schwab. It's a bit more specific because it does relate just to the idiopathic world. But it is a decent, I think a decent review of that, or classification of that. So
yeah, I should have. I'll add that to the PowerPoint before I send it to mine, so that whenever it's uploaded, it has all of them on there.
And I love Obaid's classification. I think that paper is really good. But at the end of the day, Bowes is the one that's like most clinically relevant, right? Because it just like really breaks down and simplifies how to think about these curves, I think, in the coronal plane, especially as it relates to like what we do in the operating room. That's why I really like that classification, because to me it just kind of keeps it a little simpler. How are you going to use this stuff in CAM and in practice? Like, what's your like? Do you know what I mean?
Well, yeah, I mean, I think
and
based on, well, I think at the beginning I'll have to refer back to them more, but like you said, I mean, just with the the limited conversations we've had about the BOW classification, I think it just, looking at these, it's not necessarily just being able to classify them, but understanding what the repercussions of that curve is, or that correction that you're trying to gain from that, and what your goals should be in treatment of these patients. I think a lot of times, we didn't have as much deformity in my residency, and so I didn't take a lot of these factors into account. Whereas now, when I look at these, I realize there's so much that comes into play in these patients and getting them balanced, and that you have to keep those in mind at all times when you're looking at these patients, because it's not just oh, I got to fix this curve, but you got to look at it all together and be able to use these studies and understand that there are benefits from getting these patients within these goals, and these classifications help guide you to what potential treatments they need. So I think it just helps put the puzzle pieces together better than trying to look at it as just like I got this coronal curve, I got this middle curve, let me fix these both. This gives you goals and kind of shows outcomes of when you do meet these goals.
Awesome. Any other questions from the group that's on?